presenters today are Christopher Ofodaro, is already online, and also Dr. Oluseyi Apola is also online too. And the topic today is posterior communicating PCOM-Aneurysm, posterior communicating artery aneurysm. Okay, one of the common aneurysm we encounter in our patients here in sub-Saharan Africa. And they will take us through this topic. They will start with a case presentation first, and they will tell us about the vascular anatomy of posterior communicating artery, and also the management protocol for these patients. Our faculty is also here. There's no other person than Professor Tayo Ojo, a renowned neurosurgeon in Lagos University Teaching Hospital. So the modalities for this presentation will be, the first presenter will have 30 minutes, and the second presenter will have 25 minutes. After that, we're going to have a Q&A where our colleagues can ask questions, and they'll be responded by the presenters who answer the questions the best way they can. Then subsequently, we formally introduce our faculty, who is going to give us a general talk and tenets and advise us on this topic. Then also introduce senior faculty members that are present in the webinar, so they can also lend their thoughts on this topic. And without further talk, I would like to introduce our colleagues in University College Hospital to please take over the discussion. I think Dr. Christopher Fodaro is the first presenter. Please, can you put your slide on SlideShare and start? Thank you very much.
Yeah, thank you for having us. So this evening, we'll be presenting posterior communicating artery aneurysm. We'll be using this outline. First, I'll start with the case presentation. She is Mrs. A.T., a 45-year-old right-handed woman who presented to us with recurrent headache of 3 months duration. She had 2 episodes. At the second episode, she came with investigation results. She presented with sudden headache with a pain numeric scale of 10, described as the worst headache of her life, relieved temporarily with analgesic. There's history of drooping of the left upper eyelid. There's no loss of consciousness, no neck pain, no neck stiffness, no seizure, no differential limb weakness. There's no photophobia, no vomiting. There's no comorbidity. Admitted GCS was 15 with normal metal status. The pupils on the left is 6 mm unreactive. On the right, it is 3 mm brisk. There's leftosis. Examination of systems of the systems were essentially normal. Make a diagnosis of ruptured posterior communicating artery aneurysm. These are the neuroimaging, some of the neuroimaging she came with. This is the CT angiography, MRI angiography, which showed a bulbous swelling in the region of the posterior communicating artery. And this is an intraoral imaging showing the dilatation, the aneurysm. This is the ICA. This is the optic nerve, and this is the oculomotor nerve. You can see some compression, some contact between the aneurysm and the posterior oculomotor nerve. Patient subsequently had clipping, and this is the post-op angiography, which showed obstruction of the aneurysm. By way of introduction, posterior communicating artery aneurysms are among the most common intracranial aneurysm. These typically arise at the junction between the internal carotid artery and the posterior communicating artery, which is the most common type. Though it can also occur at the trunk of the posterior communicating artery, which is the true posterior communicating artery aneurysm. These aneurysms, they are clinically significant because of their proximity to critical neurovascular structures like the perforators in the posterior communicating artery and the anterior choroidal artery. And this group of aneurysms have a higher risk of rupture when compared to other aneurysms. The posterior communicating artery connects the anterior circulation, which is mainly supplied by the internal carotid artery, and the posterior circulation, and is an integral part of the circle of Willis. As its supply, it serves as a collateral pathway in case of cerebral ischemia. The aneurysm arises from the posteromedial part of the internal carotid artery and causes medial to the oculomotor nerve, and pierces through the membrane of Liliequist to enter the posterior cerebral artery at the junction of P1 and P2. At this point, close to the posterior communicating artery is the anterior choroidal artery. This artery is a very supplies key structures, key cerebral brain structures. Hence, preservation of this artery in the course of clipping this group of aneurysms is very important, because accidental clipping of the anterior choroidal artery could cause some neurological deficits, since it supplies some part of the cerebral peduncle, the optic nerve, and internal capsule. And also, because of the proximity to the oculomotor nerve, once these aneurysms occur, they could, especially the posterolateral one, patients could present with ptosis. Also close to this, also important in the relevant anatomy, is the optic nerve. The optic nerve arises from the optic canal close to the internal carotid artery, where it enters to the intracranial cavity. At this point, in the course of microscopical clipping of aneurysms, of PCOM-Aneurysms, there is need for more dissection at this region to obtain proximal control in order to prevent intraoperative rupture. Also important in this location is the falciform ligament, which is attached to the anterior communicating artery, anterior clinoid process, to the posterior roof, to the roof of the optic canal. So there's need at times to incise this ligament in order to gain more working space. And also, the clinoid process may also be removed in order to improve space in course of microsurgical clipping of this group of aneurysms. This is a mistake here. This is the function of the anterior choroidal artery, the structures supplied by the anterior choroidal artery. Then important also in the anatomy is the perforative branches of the posterior communicating artery. There are about 2 to 8 branches of importance, and the most important of these is the premammillary artery, which supplies the hippocampus and other internal important structures. Hence, there is need to preserve these perforators in microsurgical clipping of this group of aneurysms. Then, by way of embryology, the internal carotid artery embryologically divides into anterior and posterior division. The posterior division gives rise to the fetal posterior cerebral artery and the posterior anterior choroidal artery. The posterior choroidal artery, with time, as the fetus develop, merges with the posterior cerebral artery, while the fetal posterior cerebral artery regresses to form the posterior communicating artery. If there is persistence of the fetal PCA, and with sole supply to the posterior circulation, this is termed as the true fetal circulation. But if there's an hypoplasia of the M1, of the P1, this is the fetal type PCA. This anatomical variant is important. It has been observed that patients with the fetal posterior cerebral artery, they are at risk of formation of aneurysms in the posterior communicating artery.
And also the risk of subarachnoid hemorrhage in this group is usually high. Now, this is a study that was carried out, that was published in the Asian Journal of Neurosurgery, whereby they look at 170 human cadaveric brain, whereby they studied the posterior cerebral artery, and they observed some variabilities in this group of cadaver. And of the most common origin was the one from the internal carotid artery that terminates at the point of the junction between the P1 and P2. They also observed that some group of the cadaveric brain, there's aplasia of one of the posterior communicating artery, and they also observe hypoplasia in other group. Then some of the artery were fenestrated. Then at the point of termination, most of them terminated at the junction between P1 and P2. Then some terminated at the basilar artery. Then other were fenestrated. Then some terminated at a vascular loop that connects the posterior circulation and the posterior communicating artery. And then there is another group of this brain that were sole supply of the posterior circulation. There was no communication between the anterior circulation and the posterior circulation. This variability is important. It emphasizes the need to preserve the posterior communicating artery in the course of clipping these aneurysms, because injury of this could lead to some neurological deficits. Now we look at the anatomy of the aneurysms. The aneurysm has different components. It has the neck, which is the point of communication between the parent artery and the aneurysm, and the aneurysm, and is also the site where clipping is. The clipping, vascular clip is applied. Then the dome, and then the fundus. The fundus is the tip of the dome, which is the thinnest part. In the course of microsurgical clipping, it's good to attain a proximal control before manipulation of the fundus or the dome, because the risk of intraoperative rupture is very high. This is a study that was that looked at angiography study of 313 patients with posterior communicating artery, looking at the different morphology of this aneurysm in this area, and they came up with eight classification. The type 1 is the true aneurysm, whereby the aneurysm arises from the trunk of the posterior communicating artery. Then the type 2 is the most common type, where the aneurysm occurs at the junction between the internal carotid artery and the posterior communicating artery. Then in other group, they observed that the posterior communicating artery arises from the fundus of the aneurysm, or that it lies proximal to the aneurysm without attachment. Then in type 5, there's an attachment to the dome of the aneurysm. In type 6, no posterior communicating artery was visualized. In type 7, is distal, the posterior communicating artery is distal to the aneurysm without attachment, while in type 8, there is some attachment to the aneurysm. But in this study, they also look at the risk of rupture in this group of aneurysms that were noticed in this patient, and they observed that the type 2 and the type 5, which occur at the point of bifurcation, the risk is usually higher. We look at the classification of aneurysm in this region. It can be classified based on anatomical origin, as I said previously. The junctional ones is the one that arrives at the point of at the junction between the internal carotid artery and the posterior communicating artery, and this is the most common type. Then the true posterior communicating artery aneurysm, this occur from the posterior communicating artery trunk itself. These are usually rare, but very important to note this group of aneurysms, because the perforators, which supply critical neurovascular structures, are located in this
in this region. So this aneurysm can also be classified based on morphology into circular and fusiform. Circular is a dilatation of a part of the vessel, while if there's a syncofacial dilatation of the vessels, this is referred to as the fusiform. Also important in the classification of this group of aneurysms is the projection, which could be posterior, inferior, is anterior, no, posterior, inferior, superior, and medial. The posterolateral group, they are the most common, and most of the patients with the posterolateral group, like the case we presented, usually present with cranial nerve 3 palsy because of the relationship. And also important in the projection is it aids surgical planning of these patients. Then the aneurysms also could also be classified based on size. Once it's greater than 25 millimeter, this is classified as giant aneurysms. Now we look at the true posterior communicating artery aneurysms. This usually arises from the trunk of the artery, and usually not attached to the internal carotid artery nor the posterior cerebral artery. They are usually rare and usually associated with fetal type posterior communicating artery anatomy. And this group of the patient with this group of aneurysms, they have a higher risk of subarachnoid hemorrhage, and usually surgical management is usually technical because of the perforators that arises from these aneurysms. And this is a study, a literature review that looked at studies on cases on true posterior communicating artery aneurysms. And in their analysis, they observed that this group of aneurysms occur both at the proximal, middle, or the distal part of the trunk of the posterior communicating artery. 85% of the cases that were looked presented with subarachnoid hemorrhage, and that 72 of them has the fetal type posterior communicating artery circulation. So, and this is the different projections that we observed in the study, and most of them were inferolateral. Now we look at the pathophysiology of aneurysms. Aneurysm occur at the point of arterial bifurcation, which is the point of maximal hemodynamic stress on the vessel. And in this, usually there's some structural weakness at the point of this bifurcation. This diagram looks at the histology of the normal cerebral artery compared to the ones with intracranial aneurysms. And you can see that there are pignotic cells in the intima and with some signs of degeneration of the tunica media. And there's also missing endothelium. At this point of this degeneration, it usually leads to outpouching, which leads to aneurysms. And once also other factors that contribute to this formation of these aneurysms include hemodynamic factors, which I said previously, and also inflammatory process has also been implicated. Once this formation occurs, the aneurysm can grow, it can rupture, and once it ruptures, there's a second chance of rebleed. Then it can form thrombosis, and once thrombosis is formed, it can also recanalize. Then the risk of rupture increases when on rupture aneurysm is symptomatic, about 6% per year, and the risk of rebleeding after rupture increases to 15 to 20% within 2 weeks. Now, some of the risk factors that increases the risk of rupture could be aneurysmal factors, patient factors, and environmental factors. And in this study, they looked at 432 patients, angiography of patients with posterior communicating artery aneurysms, and they observed that some morphology that are associated with rupture in this group of aneurysms. And these are some of the findings that were significant. The irregular morphology of these aneurysms, multilobulations, daughter domes, and higher aspect ratio. Now, upon rupture, the aneurysm, upon rupture, there is a rupture of this aneurysm leads to subarachnoid hemorrhage, which causes some meningeal irritation, and patients will present with signs of meningism, and also leads to raised ICP with consequent cerebral hypoperfusion. This could also lead to vasospasm because of the presence of of hemoglobin and other blood products, and it leads to narrowing, which could lead to delayed cerebral ischemia. Because of the proximity of the cranial nerve artery, this patient could also present with oculomotor nerve palsy. Then, because of the proximity to the temporal lobe, once there is a rupture, there is risk of blood entering into uh, the temporal on of the ventricle, and this could cause obstruction and subsequently hydrocephalus. Also, because of the increase because of the sympathetic surge, patients could have some systemic manifestation involving the heart, the lungs, and metabolic issues. Now, these are some of the mechanisms of vasospasm. It could result from both endothelial dysfunction, inflammatory activation, then smooth muscle contraction, especially when there is influx of potassium of calcium, and is the use of nimodipine, calcium channel blocker in the management of this group uh, of of patients with vasospasm. So this is the systemic effect from the sympathetic surge. Patient could present with cardiac dysfunction, pulmonary edema, electrolyte imbalance. Thank you.
Good evening, senior colleagues and colleagues. I'll be taking the clinical evaluation and management of PCOM-Aneurysms. And the patients may be asymptomatic. Sometimes they present with sentinel headaches, which is reported in 50% of patients. Most of them would have the sentinel headache within 8 weeks of the overt subarachnoid hemorrhage, and it could be lateralized in 30% of cases to the side where the aneurysm is. Thunderclap headache, which is described as the worst headache of patient's life, is the most common symptom, which could be associated with neck pain and photophobia. They could also have mass effects, particularly compression of the oculomotor nerve, which would make the patient to present with ptosis, mydriasis, and diplopia. And in this instance, the patient's eye on that ipsilateral side will be down and out. They could also present with symptoms of raised intracranial pressure, which could result from hydrocephalus or excessive bleeding to the subarachnoid or subdural space. They could present with loss of consciousness. Sudden death occurs in about up to 15% of patients. They could present with seizures, delayed cerebral ischemia from vasospasm. They could also have congestive heart failure and pulmonary edema from sympathetic overdrive. And those are known causes of mortality in these patients, aside the acute raised intracranial pressure. There are some atypical presentations of the PCOM-Aneurysm, and two case reports are shown in this slide. The one to the left talks about a PCOM-Aneurysm presenting with facial pain, symptoms suggestive of trigeminal neuralgia. And in this instance, they found out that the aneurysm was bilobed and it was compressing on the trigeminal nerve, so it presented with facial pain. And in the second case report, the one to the right, the patient presented with hemiparesis because the aneurysm was compressing on the corticospinal tract in the crura. The important signs that the patient may present with include fever, coma, meningism, focal neurologic deficits in terms of oculomotor palsy or hemiparesis. They could also have ocular hemorrhage, which can include subhyaloid hemorrhage, which is pre-retinal and may be associated with high mortality rates. They could also have intraretinal hemorrhage. They could have hemorrhage into the vitreous humor, which is referred to as a Tessin syndrome. This is the World Federation of Neurological Surgery grading of aneurysmal subarachnoid hemorrhage, as shown in this table. And this is the Hunt and Hess grading, which is also based on the clinical presentation of the patients. And right below is a modification of the Hunt and Hess, in which we now have a grade 0, which represents the unruptured aneurysm, and grade 1A, in which there is no acute meningeal irritation. The investigations that could be done could include a plain cranial CT, which is best done within 6 hours of subarachnoid hemorrhage with sensitivity and specificity nearing or about 100%. The lumbar puncture could also be done. Cranial CT angiogram, cranial MR angiogram could also be done, but does not have the sensitivity and specificity of a CT angio. Digital subtraction angiogram is the gold standard, and some other investigations would be important in these patients, knowing that they could have some other systemic manifestations, chest X-ray, ECG, echocardiogram, routine laboratory investigations, particularly the EUCR, because they could have hyponatremia. The cranial CT scan, the plain CT, the things to look out for will be the ventricular size, in which case acute hydrocephalus could occur in up to 21% of cases. Hematoma could be present, intracerebral, subdural, and the presence of bleed or hematoma within the cystines and fissures could be prognostic, could be a prognostic index for vasospasm. One could also predict the location of the aneurysm, judging by the pattern of hematoma or hemorrhage on the plain CT. And multiple aneurysms in particular, it helps because it gives one an idea of where it could come from. And bleed in the Syrian fissure, ipsilateral Syrian fissure, could actually point to PCOM-Aneurysm or mid-cerebral aneurysm. Temporal intraparenchymal hemorrhage sometimes occur in some instances, and the patient could also bleed into the temporal horn of lateral ventricle. These images show the PCOM-Aneurysm. To the extreme left is the CT angiogram, while in the middle is the MR angiogram, and to the extreme right is the catheter angio, which is the gold standard. And this table shows the fissure grading, which is based on the findings on neuroimaging. And this is a modification of the fissure grading and the chances of vasospasm in each of the grades. With lumbar puncture, one could check the opening pressure, and I mean, one could also judge with the color of the cerebrospinal fluid that comes out, but one should expect it to clear out. One would with subarachnoid hemorrhage, acute subarachnoid hemorrhage, one would not expect it to clear out, but if one subjects it to spinning, the supernatant might be xanthochromic because of the breakdown product of the red cells, but one should look out for false positives because patients with jaundice can also have xanthochromic CSF. Xanthochromic CSF can be detected up to 4 weeks post-ictus, 40% of cases. The red cell counts of the CSF collected might be more than 100,000, and protein level could be high, glucose could be reduced or normal because of the metabolism by the red blood cells. And the goals in the management of the ruptured aneurysm would be to prevent rebleeding, which is a major concern, to diagnose and treat hydrocephalus promptly, prevent vasospasm, diagnose and treat hyponatremia and hypovolemia, prevent deep venous thrombosis, manage seizures, augment cerebral oxygen delivery, and determine the source of bleed. And the care is multidisciplinary. and one will need to nurse the patient in the intensive care unit, hourly vital signs check, blood pressure control, analgesia, maintenance of euvolemia, preventing vasospasm by giving nimodipine, cough suppressants and laxatives are also given because they tend to cause elevated intracranial pressure and could encourage rebleed. Anesthesia medications are given and physiotherapy is ensured. Pneumatic compression device is applied, fever is managed, and the options of care would include non-surgical care, particularly if the aneurysm is less than 7 millimeters. And particularly in the anterior circulation, one could observe in such instance. The options of care that are surgical include endovascular surgery, which and flow diversion. Flow diversion could also be endovascular most of the time. It is. And open surgery would include clipping and wrapping, and some equipment apart from the basic craniotomy equipment that are needed for the procedure will include the microscope, generous array of aneurysm clips, clip applicators, and radiolucent head holder, evoke potential, that's the motor and somatosensory evoke potentials, intraoperative arteriography in the cyanin green to monitor after clipping to be sure that the neck is completely occluded and that the perforators are not included in the clipping. So these are some of the options in the corridors one could follow in managing these patients surgically, and the terminal is the most commonly deployed in these patients. The indications of coiling will include instance of multiple aneurysms, severe vasospasm, extremes of age, presence of mycotic, fusiform, and dissecting aneurysm, blood blister-like aneurysm with very flimsy wall, and then PCOM-Aneurysms coexisting with AVM. In some instances, one may also, clipping might be the best option, particularly in the instance where there's a lot of hemorrhage or hematoma to clear from the intracranial space. In the instance where the neck is too wide, presence of blood clots within the aneurysm or calcification. And usually in the young, one would rather do clipping because if one goes for coiling, there might be need for multiple revisions in the course of time. So those are instances where one may do clipping. So these are diagrams showing the surgical steps for terminal craniotomy. And the first to the left shows positioning of the patient with the application of the head holder, Mayfield head holder, and marking of the surgical site, incision site, which is usually from 1 cm anterior to the tragus and extends curvilinearly to the widow's peak. And the patient is positioned, about the head is elevated about 20 to 30 degrees and turned about 15 to 30 degrees contralaterally, and a shoulder roll is applied. The second picture shows the skin flap has been raised, and superficial dissection of the temporalis is done, and then a cuff of muscle of the temporalis is left for closure, and the third image, that's to the extreme right, shows that the craniotomy has been done, and this could be achieved by first locating or making the keyhole borehole, and then another borehole is placed just superior to the root of zygoma, and using the craniotome, the craniotomy can be completed. The sphenoid ridge is taken down, and is taken down up to the point where one gets to the suborbital fissure, or the meningoorbital band could actually point one to where one needs to stop. And then the anterior clinoidectomy might need to be done to create more space. The roof of the orbit can also be drilled to also create space in the frontal corridor. And one would open the dura as shown, and there might be need to also incise the ligament, the falciform ligament. And the Sylvian fissure is dissected such that the entire extent of the internal carotid artery is seen, and the opticocarotid cistern is opened, which would enable one to put a temporary clip, which would enable one to dissect the neck without much ado. So after opening that, one could locate the aneurysm either by going through the frontal corridor, if one follows the ophthalmic, the what's the if one follows the olfactory tract, pardon me, and then follows it posteriorly, follows the medial stride, one will be able to get to the optic nerve. One will see the optic chiasm, the optic tract, and the posterior communicating aneurysm would actually be below the optic tract and in between the optic tract and the oculomotor nerve. The oculomotor nerve is actually inferolateral to the aneurysm usually, or to the PCOM. So one could locate the aneurysm that way, or one could actually follow the sphenoid ridge, which will lead one to the anterior clinoid process, and one at that point could recognize the optic nerve, the optic tract, and follows it as earlier described. So this shows the relationship of the PCOM with the optic chiasm, the optic tract, the oculomotor nerve, as described earlier. And one will need to dissect the neck of the aneurysm, and as much as possible, one should not dissect the dome of the aneurysm, because that is a recipe for rupture, op rupture. And this is the falciform ligament on the left, as shown here. Releasing it may prevent the tethering of the frontal lobe, because one could retract the frontal lobe to create space, but it's advisable that one should not retract the temporal lobe, because the dome of the aneurysm could be attached to the temporal lobe, and retracting it could result in bleeds. To the extreme right shows the different morphologies of the lobes of the dome of the aneurysm. It could be bilobed, it could be supratentorial, and it could be infratentorial. And this shows the clip already deployed to the neck of the aneurysm in these pictures. These are the things one will need to request for in form of post-op order after aneurysmal clipping. And in terms of anatomical nuances and variants, one needs to be aware that most PCOM aneurysms arise at the ICA PCOM junction, and in some instances, it could be a true PCOM aneurysm which occurs more distally, and in such instance, it places the neck in a blind spot in the traditional terminal approach. So one should also be aware of the fact that there could be fetal type posterior cerebral artery in which the PCOM is dominant, and PCOM infundibulum could also be misinterpreted as an aneurysm. And the PCOM infundibulum is found at the point where the aneurysm, where the PCOM emerges from the internal cerebral artery. It's usually funnel shaped, less than 3 mm, but it hardly bleeds. And so one should take note of that. And then one should also take note of the anterior choroidal artery of which if one dissects the Syrian figure properly, it will show, one will be able to recognize the anterior choroidal artery, and then one should also take note of the oculomotor nerve so that one does not include them in the process of clipping. An anterolateral dome orientation could obscure the neck of the aneurysm. One should look out for that, and may also adhere to the anterior clinoid. And in this instance, one is advised to dissect cautiously. A superlateral dome will point towards the medial sphenoid ridge, and this is the type that is likely to cause a subdural hematoma. Posterolateral superior dome will point towards the medial temporal lobe and could be adherent to it. While the posterolateral inferior dome projection would mean that the aneurysm dome is pointing in the interpeduncular fossa. There used to be debate about early and late surgery, but at the moment, the consensus is that aneurysm clipping or coiling should be done at the next available list for next available elective list. So, I mean, it needs to be attended to as soon as possible. Some signs of imminent rupture will include progressive perianal palsy, increase in the aneurysm size if one repeats the angiogram, and beating aneurysm sign on CT angio or MR angio. Minor hemorrhages or sentinel hemorrhages could also be pointers to imminent rupture of the aneurysms. And the international study of unruptured intracranial aneurysm, ISRA, looked at the size and location, concluded that the size and location are two most important factors that influence the rupture of the aneurysms. And it's been found that posterior circulation aneurysms are 8 to 14 times more likely to rupture than the anterior counterparts. And the phasis score is displayed in this slide, and it shows the different components of it. The population or the race of the patients is important because it's commoner in the Japanese and Finnish, and usually it is said that it's usually a genetic thing, though it's not fully understood why it is commoner in them. And presence of hypertension, age, the size, and the total score is 0 to 23 as shown here. And this shows the 5-year rupture risk with the phasis score in each of the patients with a greater than 9 phasis score, making the patients subjected to a rupture risk of greater than 17%. And this shows the findings from the ITRI study, in which case the less than 7 millimeters anterior circulation aneurysm has a 0% chance of rupture in 5 years, while the posterior circulation aneurysm less than 7 mm has a 2.5% rupture chance in 5 years. And as the aneurysm increases in size, the risk of rupture increases to 40% in anterior circulation if it's greater than 25 mm, and 50% in posterior circulation if it's greater than 25 mm. To prevent rebleed, the chance of rebleed is highest in the first day, and it's most of the time 50% rebleed will occur within 6 months. Antifibrinolytic therapy can be given within 72 hours, and that comes into level 2 evidence. The magnitude of blood pressure control to reduce the risk of rebleed has not been established, but it's advised that one reduces the systolic blood pressure to less than 160 millimeters of mercury. And talking about cerebral vasospasm, it almost never occurs within the first 3 days, and its maximum frequency is within the 6 to 8 days of ictus. And usually the at-risk period is quoted to be 3 to 14 days. And generally, a clinical cerebral vasospasm would resolve by 12-day post-ictus, and a radiographic cerebral vasospasm will resolve within 3 to 4 weeks. And the diagnosis of cerebral vasospasm can be clinical or radiological. And sometimes the finding of clinical vasospasm may not correspond to a finding of a radiologic vasospasm. And the reason for this is not known. The management of vasospasm will include the maintenance of euvolemia, which comes to the level 1 evidence. One could also induce hypertension, but one should pay attention to the baseline blood pressure of the patient. That comes to the level 1 evidence. Endovascular angioplasty could be done, and some people insert stent as well. Intra-arterial vasodilator therapy could also be done. The use of nimodipine and ranitidine receptor blockers are also employed. But it's important to know that nimodipine does not reverse the vasospasm in such patients, but ranitidine receptor blocker has been shown to reverse the vasospasm. Many older schemes used to refer to treatment of vasospasm as triple H, but that has been scrapped at the moment. What is the management modality is now referred to as hemodynamic augmentation, which will include basically maintaining euvolemia and inducing arterial hypertension. And this shows the alternate grade at the chance of clinical vasospasm in patients. Hyponatremia could occur as a result of cerebral salt wasting and syndrome of inappropriate ADH. That should be looked out for and managed as appropriate. The risk factors for subarachnoid hemorrhage are listed here, and the aspect ratio is important because if it's greater than 1.6, it particularly increases the chance of an acute subarachnoid hemorrhage. Talking about our unit experience, this is a prospectively acquired clinical radiologic data of all patients with angiographically confirmed aneurysm between 2009 and 2026. And we managed a total of 37 angiographically confirmed PCOM-Aneurysms in this period, and it accounted for a total of 26.8 of the total aneurysm we managed in that period. 18 were right-sided, 19 were on the left. The age range was 23 to 79 years, and there were 4 males and 33 females in this series. And all the patients were symptomatic, with 37 of them, that is, all of them had headache, and 89% of them had ptosis, 25% had neck pain, while 13% had altered sensorium. And the table shows the WFNS grade of the patients and the number of patients that had such. All the patients presenting, in conclusion, all patients presenting with subarachnoid hemorrhage require prompt imaging. In particular, clinicians should have a high index of suspicion of PCOM-Aneurysm in patients with headache and unilateral oculomotor ptosis. And attention should also be placed in the instance where a patient may present with atypical symptoms of the same disease condition. Thank you very much for listening. These are some of the selected references. Thank you.
Yes, thank you very much, Dr. Christopher and Dr. Akpola, for this very interesting presentation. And thank you for keeping to time. PCOM-Aneurysm is one of the commonest aneurysm that is managed in sub-Saharan Africa. And they presented a patient they managed in their center that had PCOM-Aneurysm, and they showed us pre-op and post-op images of how the aneurysm was secured. I would like to move on to question and answer session now. Please, if you have any question, you can either unmute yourself and ask the question, or you can type it on the chat box so that we can ask the presenters.
Okay, so come and film this segment.
Hello? So there was a question that is posted. Hello? Does anybody have a question to ask? Please, you can indicate by raising up your hand and you'll be recognized to ask your question. There's a question in the chat box by Ndubisi Kenneth, and this is for the presenter, I think the second presenter. He said, thank you for the presentation. Is there any reason why posterior is likely to rupture than the anterior? Dr. Abola and Dr. Christopher, I don't know if you can respond to that. Is there any reason? I think that it means the projection of the PCOM-Aneurysm. Is there any reason why the posterior projecting aneurysm is likely to rupture than the anterior projecting ones?
Okay, thank you very much, sir. Well, if I got the question right, I'm not sure the person was talking about the projection of the he was talking about anterior versus posterior aneurysms and why the anterior aneurysms, posterior aneurysms are more likely to rupture than the anterior. The reason is actually not established why the posterior communications, the posterior aneurysms are more likely to rupture compared with the anterior. A number of factors or risk factors are looked at. Location-specific factors and the vulnerability in that location, the presence of hemodynamic stress, which is found to be worse in the posterior circulation than the anterior circulation. Those are some of the things, risk factors have been recognized, but the reason why is really not established in the literature. Thank you.
All right, thank you very much. Yes, the next question is, what BP range and MAP range is ideal post-clipping and during vasospasm? That question is from Dr. Annie Kingsley. So he was asking about the blood pressure range and MAP range, for the optimal blood pressure and MAP. Yes, post-clipping.
Yes, thank you very much, sir. Before clipping, let me start from there. Before clipping, there's a bit of controversy because the specific blood pressure that will prevent you bleed is not known. But it is advised that the blood pressure, the systolic blood pressure, be kept between 120 to 160. It should be less than 160 millimeters of mercury. And post-clipping, I would want to think that the normal range of blood pressure should just be maintained in such patients. And even in vasospasm, it is advised that one should induce hypertension, but care should be taken because there's a risk of rebleed, and one should ensure that the blood pressure, systolic blood pressure, does not go above 160 millimeters of mercury. Thank you, sir.
All right, thank you very much. We have a lot of questions in the chat box. There's another one from Dr. P.H. Yatu. He thanked you for the presentation and he said, what situation would one use subfrontal and the inter-ischemic approaches to clip a PCOM-Aneurysm? So in what situation do you prefer to use a subfrontal and inter-hemispheric approach? That's a question by Dr. Yatu. I think yes.
Yeah, thank you very much. For the subfrontal approach, if the aneurysm is pointing posteriorly or posterolaterally, it gives one access to the neck of the aneurysm early, and one would be able to dissect it without much ado, without having to tamper with the dome of the aneurysm. And in such instance, a subfrontal approach might come in handy. And also, we talk about the choice of approach depending on what the surgeon is capable of doing. And then for the interhemispheric approach, if the aneurysm is pointing anteriorly, one could use the interhemispheric approach, particularly if it's directed into the interpeduncular fossa. One might want to use that because one will be able to get to the neck of the aneurysm, which is important. But it's important in the choice of the approach to study the image appropriately, because one will need to know where the dome of the aneurysm points to, and that would inform the right choice of approach for such aneurysms. Thank you, sir.
Yeah, so take the last question now. I think it's from the same person, Dr. Yatu. He is asking, in case of, how do you handle an intraoperative rupture of aneurysm during surgery? That should be the last question from the chat box. But any other person that wants to ask question can also unmute and ask. Thank you very much. Please go ahead,
Thank
Doctor.
you very much, sir.
Yes.
With a temporary clip, if one is able to put a temporary clip on the internal carotid artery, either in the optical carotid system, or sometimes one could do that in the neck, expose the internal carotid in the neck and deploy a clip. In such instance, one would be able to prevent rupture or undo the rupture better. But if the rupture happens, one will put a cotinoid over the area of rupture and suck on the cotinoid and identify the neck of the aneurysm to clip it if one can. And if the temporary clip was not deployed previously, putting a cotinoid and sucking on it, which will apply some pressure over the bleeding area, could allow one the chance of deploying the temporary clip if it wasn't deployed previously. Thank you.
Yes, also interesting. In addition to that, to that question, preparation, you need to anticipate possible rush for every aneurysm case. Okay, so your clips should be available, they should be prepared, they should be available. You must inform the anesthetist in case there's a risk of rupture, and they should follow the protocol of intraoperative hypotension and so on. So it's a team-based approach, okay? You let the anesthetist know, the team has to be prepared in case that occurs. Thank you very much. I don't know if there's any other question from other members, colleagues on the webinar before we introduce our faculty. Okay, any question? Okay, I will call on to our faculty now. Our faculty is Professor Tayo Ojo. He's a consultant neurosurgeon and a professor of neurosurgery at University of Lagos and LUTH. He's a fellow of both the West African College and the National College of Surgeons, also a member of the Royal College of Surgeons of England. He is very senior faculty member, also an examiner of the college, and he has had undergone many fellowships outside the country, including the WFNS fellowship in Tübingen, Germany. He's our former Secretary General of NANS, as a parent association, and he's also the current Assistant Secretary General of CANS. I want to introduce Professor Tayo Ojo. Please, sir, thank you. Please, you can unmute yourself and give us your comments, sir. Thank you very much. Hello. Hello, I don't know what Prof is. As we wait.
Hello, can you hear me?
Okay, yes, I can hear you.
Yes, sir.
All right, sorry, the network went off.
Yes, I'm aware. Yes, I'm aware.
Let's say a very big congratulations to the presenters. They actually dealt with the topic exhaustively, and they paid particular attention to details, which is expected in management of intracranial aneurysm, especially as it relates to PCOM-Aneurysm. And I'm so happy that the anatomy was well discussed, because sometimes you have a stereotyped image of PCOM artery, and at surgery, you may find something else. Therefore, so that I don't waste too much time, I will go to my overview, and I'll be very brief about it. I will also try to answer some questions that were earlier on asked, and maybe a few clarifications on some of the issues that were mentioned earlier. So, can you see my slide?
Yes, sir. Yes, sir. You can see your
All
slides
right.
clearly, sir. Yeah.
I'll be very brief with you. So, looking into the literature, I think we should be ready for vascular management of aneurysm, because in many places, in many countries, it is becoming the gold standard. However, I think we still have some time to go before we get there. In many instances, we have the endovascular guys doing everything. In other places, we have the microvascular guys probably doing all the aneurysms. Basically, there will be factors that will determine which one is which. And it has been mentioned, the patient factors and the aneurysm-related factors. For younger people, clipping is always better because they have time to live, and the rate of recurrence is lower in clipping, unlike in coiling, where the risk of recurrence is higher. The aneurysm factor, but however, the neck of the aneurysm, I think, with the modern techniques of neurovascular, endovascular intervention, they can do different types of aneurysm, wide neck, small neck, and so on and so forth. But just to know, the hard joints, we did a study in Luz, and we'll try to see what is necessary for good outcome, aneurysmal subarachnoid hemorrhage management. And we realize that illumination is better, because with that, you see what exactly you want to do. Magnification, so that you may probably appreciate the perforators. It's a multidisciplinary approach, so it's not a one-man game. So you still need intensivists and so on and so forth. ICU backup, rehabilitation, and you need the surgical drill. For PCOM aneurysm in particular, because of the mass effects that can cause ptosis, it's been postulated that surgical clipping makes it quicker for resolve. The imaging is important: CT angiogram, digital subtraction angiography, and this will delineate the anatomy, the fetal PCOM, which was discussed, the anterior choroidal artery, and especially the dome of the anatomy. It is important to be clear about the dome of the aneurysm, because it helps in planning the surgery. So when you do the CT angiogram, it's not enough to say that the aneurysm is there. You also have to tell about the configuration of the aneurysm. Basically, you want to see it in 3D, as you can see in the image on the right, whereby you can probably appreciate the perforators, the vessels that are close by, and that can guide you as you approach. Now, the first thing to do when you open is to let out CSL. When you do that, as you can see in the video, even if the brain was hungry, swollen, It gives you time or space to retract minimally as you approach the aneurysm before you eventually put a clip into it. So you have to look for the perforators. If you don't see the perforators, you mistakenly get them, the consequence may be catastrophic. And if the anatomy is not clear, you have to be extremely careful. And I mentioned the CSF aspiration. Proximal control, it has been discussed earlier, but it's so important because it has to be as proximal as possible so that you can have space to dissect the neck. You can have a better angle of attack and be able to manipulate pressure. Sylvian fissure split, it's not all the time, but you really have to open all the Sylvian fissure because you are dealing with issues around the cellular paracellular region. So if you do the proximal and the medial Sylvian fissure split, you may just be fine. The lateral may not be necessary. And once you split the Sylvian fissure and you let out the CSF, you have better approach with the aneurysm, more relaxed. So retraction, with retraction, without retraction, the early part of the learning curve, you may need to retract. The others, if you have done enough, maybe not. I know that what is so scary to many people is what happens when it inadvertently bleeds while you are operating. Please note, proximal control may be fine, but if the patient is old enough or has a lot of atherosclerotic plaques, your proximal control, as you can see in the video, may not be perfect because the plaques will prevent occlusion of the vessels. You need to suck, do not pack. If you pack, you are pushing so much blood into the subarachnoid space. If you are calm and you maximize your time and faith, you may be able to secure it. But I think if you are past the learning curve, you may be able to clip, even sometimes take out the dome so that you can spare the perforator. So I think if you're just starting, it may be a nightmare, but over time you can secure that. The steps in PCOM, I'll just run through this, then I think I'll be done. So if you can see my image, so this is the PCOM. This is the anterior corridor. It's somewhere there. Sharp dissection is better than blunt dissection. You get committed, then you cut sharply, and that way you are able to manage everything that may happen. So here you can see the neck is free. The anterior corridor will be somewhere there. Then you can clip the aneurysm. So for me, the PCOM aneurysm is probably the starting point for most residents because the steps are clear and the variations are not so much. What to do when the brain is hungry, I think if you let out CSF, you'll just be fine. And then that should be fine. So in conclusion, so that I don't take too much time, PCOM-Aneurysm serves as a fundamental case to develop micro-neurosurgical skill because of what I mentioned. Thorough understanding of regional anatomy is important, especially what lies behind the aneurysm. I did some studies with Dr. Hoyer, and we're trying to see factors that can help in proximal control and realizing that sometimes you may need to go retrograde to get the proximal control. If you're interested in micro-neurosurgery, you should be able to open the Sylvian fissure, and you should realize that the intracranial aneurysm, especially PCOM, and all the aneurysms actually, they're actually not in the brain, they're in the subarachnoid space. And if you can open the subarachnoid space with micro instruments, you can and you should be able to clip any aneurysm. But finally, it's usually a teamwork. Few comments to the questions that were asked about interhemispheric approach. I am not sure how that came about because the PCOM aneurysm is not in the interhemispheric space. I may understand you if there are multiple aneurysms. I did one with Sonia too some times ago. The patient had an ACOM aneurysm and a PCOM aneurysm. So we had to do interhemispheric through subfrontal so that one opening can serve the clipping the two aneurysms. The blood pressure before clipping the aneurysm has to be in the range that the MAP will be about 70. So we'll be talking about MAP rather than systolic blood pressure. But once you have clipped the aneurysm, you need to increase the MAP almost immediately. It's also noteworthy that vasospasms appears in younger age group rather than in older age group because of the presence of atherosclerotic plaque. So if I have two patients, one in the 30s, another one in the 70s, with PCOM or any aneurysm at all, I'll be expecting vasospasm in the younger one. Dome anatomy is the reason you have to study the anatomy over. Dome position is the reason you have to study the anatomy over and over. You mentioned non-surgical care. I'm not sure how that works because if an aneurysm is not ruptured, it is a disaster in waiting. So you need to be careful. If there are multiple aneurysms, then you look for the Murphy's teeth, which would show us the one that has cleaved, including the fact that the bleed may be more in some places. I think by and large, we have almost covered it, and I must appreciate the YNNF for the great job they're doing, and also for the presenters for paying serious.
Thank you very much. Okay, I think we lost audio. Okay, thank you very much, Prof, for the talk. I think this is more than an overview. Really appreciate you for, apart from your busy schedule, able to join us. Really happy for your excellent presentation. I would like to recognize some other senior faculty members that are present here. I saw Professor Femi Bankole, is a former NANS chairman, is present here with us. I also saw Professor Chiazo Onya in the group. He's a provost of the College of Health Sciences in Esut. And also Dr. Badejo, a senior faculty member in UCH Ibadan. And also Professor Yomi Ogun, a neurologist, and he always joins us. We are happy to have you here, sir. You are welcomed. And also the YNF executives, Chair Mayowa Opara and co-chair Kelechi Lokuba. And also our international members that are present. I saw some people. Hello, like.
Well, thank you very much. And well done, everyone. This is Professor Yomi paying hi to everyone. Well done. Kudos.
Thank you very much, sir. We appreciate you. And very other senior members of the faculty. I don't know if the faculty members, anybody that has comments, contribution, please, you are free to make your contributions now. I saw we're up to 75 members. This is a very rich presentation that cuts across not just Nigeria, but our international members that are present here with us. So the floor is open for comments from our senior faculty members and other members present here. I don't know where Professor Bankole, whether he has any word of wisdom for us. I think he's still in the call. The floor is open for comments, please. Dr. Badejo, I don't know if she's still present with us here. If there's any comment from you, ma, we'll appreciate that. I also saw Dr. Morgan, Dr. Jolayemi, Dr. Koko. They are present here with us. All right.
Hello, everyone.
Yes.
Sorry, I'm rounding up in the operating room, but I'll see if I can rejoin to ask my comments. But I listened to all of the presentation, and thank you, Professor Ju, for your contributions.
Thank you very much, man. We appreciate you. All right. I think
okay. Maybe I can say a few words, Dr.
Okay, please. Yes, go ahead.
Okay. All right. A big appreciation to our presenters for today. We did a fantastic job. And I also want to appreciate Professor Tayo Joe. That was really a great. I wouldn't have missed this webinar because I'm so interested in vascular neurosurgery, and this was very, very important. I just wanted to add a few other things. We did take time talking about the microsurgical management of PCOM-Aneurysms, but we also need to realize that we could also approach this on an endovascular fashion. And endovascular neurosurgery is available now in Nigeria. So that's the first point I wanted to make. The second point is we do have lots of patients with aneurysms. Unfortunately, most of the time they present to us ruptured. So we would see them with subarachnoid hemorrhage and all of that. And so it's very important for all of us as neurosurgeons to appreciate this and be ready to gain the skills required to be able to sort out this patient and to improve our different centers so that we can handle these situations when they come to us. Thank you.
Yes. Thank you, Dr. Maiwa. There's somebody that raised his hand, J.U. I don't know. Please, can you unmute yourself and make your comments? I didn't really see your full name on the call. Dr. J.U., please, can you identify yourself and make your comments? Thank you.
Yeah, hi. This is John. John Nuswa. That's why it's called J.U.
Okay.
Yeah, I kind of joined late. Funny enough, I just come out of theater with a ruptured PCOM case as well. Thanks, Dr. Joe, for my Oga for this teaching. And even though I joined late, I could catch the last bit. So I've just seen that it was a PCOM-Aneurysms that's being presented today and talked about. But I joined while Mr. Joe was making a comment on the inter-hemispheric approach. For someone mentioned a question on PCOM-Aneurysms. So like I always tell my residents here and including my fellow the other day, every aneurysm has its trick and every aneurysm has its rule. Okay. In these days and time where we have competing interest with the endovascular guys, and trust me, PCOM is one of those aneurysms where we have lots of debates and overriding interest, particularly with our endovascular colleagues, because they feel all PCOMs should come to them. But we have the school of thought that PCOM aneurysms are surgical aneurysms, okay? And if you can get a clip across that neck, then you've done the patient a whole lot of good, especially while still looking at long-term outcomes of the various endovascular treatments. The rule of thumb is if an aneurysm cannot simply take a coil, if you've got to use any other assisted methods, whether it's balloon-assisted coiling or stent-assisted coiling or even flow diverters, then surgery should be highly considered. So with regards to the ACOM, Mr. Joe talked about, generally in principle of vascular neurosurgery, we look at the distance of the ACOM from the plenum sphenoidale or the anterior clinoid line. And if you've got an ACOM that is overriding, say about 10 millimeters above the anterior clinoid line, then that's where you have you can attempt an interhemispheric approach for that, especially if the dome is superior or posterior projecting. Having said that, you generally would divide ACOM aneurysms into whether it's a low ACOM or a high ACOM. And for low ACOMs, a terminal approach is sufficient. For high ACOMs, you could go the interhemispheric route. For PCOM, the advantage of surgery for PCOM is that you have the opportunity to also decompress the third nerve, okay? And if you can decompress the third nerve, results have shown that patients do well from their ptosis with surgery. Sometimes you may need to combine an anterior clinodectomy, particularly where you want to achieve a proper proximal control and take out the distal dural ring as well. Divide the distal dural ring so that you can mobilize the ICA and achieve a good, fast proximal control. PCOMs, I believe, are the most straightforward, but you need to have the technical competence, understand the anatomy of the PCOM itself. ESRG will typically divide PCOMs into various types, so almost 7 types of PCOM-Aneurysms. But generally, you need to know what differentiates from your angio, what the true PCOM is and what the false PCOM is, and have an idea of where an orientation you need to apply your clip. And then at that, some PCOMs have double domes. So you have PCOMs, especially the low posterior inferior dome type, that go behind the tent. So even during surgery, sometimes, like what we did today, you need to divide the tent so that you can see that inferior pointing dome and see the runoff of the PCOM artery itself, and get the neck exposed properly in a 360-degree fashion before you put in your clip. The other thing I was also going to add on the PCOM-Aneurysms is that sometimes you need to combine a skull-based approach. So, like the case I've just come out from today, my fellow called me that the brain was swollen, and clubbing in there, you could see that his craniotomy opening was small, his spinal ring was not properly drilled down, the subtemporal space was not properly opened up. And so all we just needed to do was take out all the dura hitch stitches he had put, bringing some gentle retraction in extradurally, and drill the whole spinal ring down flush, okay? At the same time, did a limited extradural clinodectomy. And by the time you open up, put the retraction stitches on the dura, you already had space to walk, and you could just see the optic nerve right there in your front, and open up the proximal CVN, follow up the ICA, complete your intradural clinodectomy. You got the full length of ICA that you can play around with. And the PCOM was just staring at us there. And it didn't take 45 minutes, clip was in already, and I've left him to close. So these are the things, and it all comes with practice and, seeing these cases being done and learning from people who have done a lot of these cases and improving on your technicalities. Okay, so that's all I just wanted to add. Nothing more. Thank you.
Yes, thank you very much, Dr. Oshua, for that excellent comment. I think we've spent about almost an hour 30 minutes in this presentation. So I want to thank our colleagues from UCH Badun for this excellent presentation. It was quite detailed in terms of the anatomy, pathology, and the management.
One that can be present in the group.
I also want to thank faculty, Professor Tayo Ojo, for this. He says it was an overview, but it was quite more than that. We really appreciate you, sir, and we really enjoyed and learned a lot from your presentation. And we look forward to hearing more from you. Please, sir, anytime we invite you, please kindly oblige us of your time. I also want to thank our senior faculty members present. I mentioned their names before. Professor Bankole, Professor Onia, Dr. Badejo, and other members of the YNNF, Dr. Morgan, Dr. Jolayemi, Dr. Jumudo, and so on and so forth. Please, I want to appreciate everybody that attended this presentation. Also, our international colleagues that joined us, want to thank you for this excellent presentation. I want to hand over to the YNF ESCO for them to round up this meeting. Thank you very much, everybody.
All right, thank you so much, our moderator for the day. You did an excellent job, Dr. Campbell. Thank you so much. And thank you everybody for joining in for our webinar today. It was a very enriching session. We appreciate the presenters. We appreciate our faculty, Professor Ujo. And Dr. Osua, thank you so much for that really insightful addition you gave to us. Thank you everybody for joining in. And let's remember, next month, last Friday of the month, we'll be coming again with another very important webinar. Watch out for the flyers, and let's meet again next month. Thank you everybody for coming in, and do enjoy your weekend. For all our young neurosurgeons, please, the Young African Neurosurgeons Forum is also having a webinar tomorrow at 5 p.m. Nigerian time. For our international colleagues, it's 4 p.m. GMT. Please let us join in. It's going to be a research webinar. So let's join in and learn more about writing papers and doing our research. Thank you everybody for joining in. All our international colleagues, thank you so much for joining in. We appreciate you. Have a great evening.